Hi, friends. Welcome to We Talk Facts. We have a fantastic episode today, and I hope you all will enjoy this episode. This has been on my mind for a long time, and we have had some hoops recording this episode with technical issues, but finally, we are doing it today. So, my guest is Ashley Pegg. She's an occupational therapist, and the topic for today is occupational therapy, restoring function, renewing
Thank
life.
you. Thank you for having me.
Welcome, Ashley. Okay, so let me tell a little bit about Ashley. I won't take too much. I will leave it to Ashley to introduce herself. But she's an occupational therapist whom I've worked with for a few years at my previous job, and she has a lot of experience in occupational therapy. Patients do love her, and she has been a valuable asset to patients' recovery. So, Ashley, come on, take the floor and
I'm
introduce
Ashley.
yourself.
I graduated with my master's from WVU in 2008. So I've been a therapist for roughly 17 years. I started my career as a traveling therapist. So I got to work in a variety of settings in different states. It was great to get a lot of experience with that. I have a special interest in neurological disorders like stroke and TBI. So I earned a certificate in NDT, which is neurodevelopmental treatment for adults with stroke and TBI. I work full time in a hospital setting, and I also own my own business, which is a private pay business. I contract with an outpatient physical therapy clinic, and I work independently as a home health occupational therapist, also doing home modification consulting.
Okay, so that's a pretty brief introduction. Now, tell our audience, how was your journey coming up to being an
Yeah, I've
occupational
always been
therapist?
interested in healthcare field, and honestly, whenever I went to school, I was pursuing nursing originally, and I'd never heard of occupational therapy. I'd actually learned about it in a classroom. I was speaking with a classmate who was pursuing OT. I asked her what it was. She explained everything, and I was just drawn to the fact that it was a holistic approach. It didn't just look at physical disabilities, but it also looked at the mental health aspects, the emotional and social aspects of it. So I decided to also pursue it.
Okay, all right, so that's interesting. Here is a question I had always had on my mind. So, what is occupational therapy and how is it different from other
So OT
therapies?
focuses on improving independence and participation with activities of daily living, which we call ADLs. This includes anything from self-care tasks like grooming, dressing, bathing, all the way up to what we call IADLs, instrumental activities of daily living. And that looks at things like laundry, cooking, cleaning, anything within the home. We also look at leisure tasks, work and life skills training, mental health support, and as well as addressing physical disabilities and injuries through rehabilitation or adaptations if need be. So basically, we look at improving someone's quality of life.
So, good, excellent, excellent. So, now what are the different types of occupational therapy a healthcare professional should know? Like somebody like me who should know about?
There's pediatric, there's school-based occupational therapy, mental health occupational therapy, environmental modification, work or home. So we could be contracted with a business per se to go in and look at the ergonomics of the workplace to prevent injury and also look at body mechanics. You'll find us in skilled nursing facilities, inpatient psych facilities, rehab facilities, home health, outpatient, school-based therapy, and birth to three. You also can see us driving in community mobility.
Okay. So that's interesting. I mean, it could be different in different settings. So the next question it always comes up to me is how is occupational therapy different in various healthcare
Well, the different
settings?
settings may focus on different aspects of activities of daily living. For example, in an inpatient hospital setting, we're going to be more focused on discharge planning from the hospital. So determining what's more appropriate, like what that person's independence is at that time, and what's more appropriate for the discharge. Do they need any equipment for home? Do they need to go somewhere for more therapy? Things of that nature. Whereas in skilled nursing or inpatient rehab, we're going to focus more on rehabilitation. So inpatient rehab is more intense. They'll get at least an hour of therapy a day. We're going to focus on not only self-care, but regaining balance, strength, fine motor deficits, if there's any there, we're going to focus on that. Any deficit, we're going to try to increase their independence in that area or adapt it as best as we can. In the home health setting, we're going to look at self-care as well as anything that they need to do within their home. Do they need to do laundry? Do they need to be able to maintain their hip precautions while reaching into the washer to get out their clothes? So we address safety and independence within the home, and those patients are considered homebound. They're not able to leave the home. Outpatient setting, you'll see a lot of times are certified hand therapists. They'll look more at hand injuries or hand
Mhm.
surgeries as well as shoulder. But we also can address life skills training within there. For example, if there's a young adult who might be autistic or have, a disability that that keeps them from living independently, we will work on, life skills training, what they need to do to be able to be independent to live on their own. School-based settings, which I don't really have any experience in, but what we focus on there is handwriting, posture, attention in the class, anything to make that child successful in the classroom. Mental health setting, we typically will work in group settings if there's multiple people there, and we'll focus not only on maintaining hygiene and day-to-day schedules, but also reincorporating that person into the community and managing and being aware of their emotions and behaviors. And then there's also low vision therapy, which driving can go along with that as well. There's driving therapy to assess if someone can get their license or get their license back if they've had a stroke or an injury like that. But we also will provide any education on visual equipment, adaptive equipment, and compensatory strategies for visual deficits in order to improve function in their everyday life.
Okay,
That's a
that's a
mouthful.
lot. I know I've only seen you in the inpatient setting where we have worked together in the hospital on many patients. So, do you have a preference on
I
any of these therapies you mentioned, like
Yes,
inpatient,
I love
outpatient
outpatient
setting?
setting, because you get a longer period of time to work with a patient. It's typically, just one-on-one. They're coming to you, so you know that they want therapy, they're gonna be motivated, and it's nice to have that time to, just focus on them.
And I guess
Yeah,
you develop a
absolutely, you can
relationship
build
with
that
those
rapport.
patients who you in the hospital setting. It's very acute and it's only
Yes.
few days and they're discharged. But in the outpatient setting, you develop
Yes,
that
and then you
kind
get
of
to see
relationship
more
with the
progress
patients.
that way too.
And it's somewhat of a more satisfactory
Yes, for
when you see
sure.
that kind of progress
And I don't mind home health
in the
either, because 'cause
outpatient
I've had
setting.
instances, home health where you're working on, like, for instance, I had a patient that's a farmer, and we worked on his farm chores, so it's just that's a different thing to do, every day get to go and get on a side by side with your patient and teach them how to drive and, bale hay or doing whatever they're doing, so that's also an interesting setting.
When it comes to the hospital setting, I've only seen you working with aged people, adults, and so on. But do you ever work with a
Yeah,
pediatric age
yeah, we
group in
do
the
in the
outpatient
hospital
setting?
setting too. In the hospital setting, we've seen patients with
Okay.
broken bones, being able to get themselves up out of bed, get themselves dressed, get to the bathroom, things like that, and teach their parents also to help them manage that while maintaining, like, if they're non-weight bearing or have any restrictions, we teach them how to get dressed and do all those activities without causing further injury or, with maintaining whatever restrictions the doctors have given them.
Okay. So, are there any new developments or new things on the
There's
horizon for
always new
occupational
assistive
therapy?
technology with technology today that's nice to keep up on, because you can use that in the house with
Yeah.
patients to improve their independence. I mean, things as like Alexa or Google Home have helped patients be more independent with, turning lights on or whatever it may be. So that's something that's always good to keep an eye on, especially also with their wheelchairs too. I forgot to mention we also do there's my Alexa stuff. Yes, exactly.
There you go. So, right question, and you have the
Yes.
right technology
So
there.
we also look at wheelchair positioning, and if they need specialized wheelchairs, specialized equipment with wheelchairs. So let's say someone's paralyzed and they're unable to control their wheelchair with their hands or legs. They might have to use what we call a sip and puff. It's like a straw based, or they might use head controls. So we assess what they need and what's going to be, the most beneficial for them to still be able to use their wheelchair as independently as they can. So
Yeah. So, since we're on the topic of new things, new developments, in terms of equipment, I don't have much idea about the equipments used for occupational
mhm,
therapy in terms of evaluation and treatment. Is the occupational therapy catching up with technology, or is technology catching up with the
I'd
therapy's
say the
needs and so
technology is
on?
probably well beyond our needs that we probably haven't even tapped into, honestly.
There you go. Okay. All right. So the next thing is, what are some things a healthcare professional like me or any other should consider referring someone to
I
occupational
again think
therapy?
that depends on the setting. For example, if someone's admitted into the hospital, like we were talking about, you see them for such a short period of time. So if they have a long standing injury or deficit from baseline, we're probably not going to be able to address that in that setting as much as we could in like outpatient
That's true.
or long-term or skilled setting. That I would say overall, if a patient has any change from their baseline with anything, any injury with any ability to do something for themselves, that would be an appropriate referral for OT.
Okay, that's good to know. And what are some of the work-related injuries or some disabilities that a healthcare person like me should know to seek help from
Any injury at
occupational
work
therapy?
that's causing them not to be able to perform their job could potentially be addressed by OT, as well as us, again, looking at the ergonomics of what caused the injury. We work with pretty much any disability or diagnosis you could think of. Like you were saying in the hospital, we work with orthopedic and surgical injuries, neurological disorders, respiratory disease, cognitive deficits, amputations, pretty much you name it, we can work with them.
Okay. Now, what is the goal of
The
occupational
overall goal
therapy?
of occupational therapy is to promote and restore independence in everyday life, ranging from, like I said, simple tasks up to work, leisure, just to increase the independence. And if it can't be restored, then to figure out how to adapt it to get the most participation in that area and educate the caregivers if we need to in order to help them, like prevent injuries and be able to help their loved one. Overall, the main thing we look at is improving quality of life for our patients.
Okay, that's good. Now, I had some questions which, for the younger generation, if you don't mind taking a couple of questions. When somebody who's younger, who's looking into pursuing occupational therapy, what's your advice to them?
My advice is definitely to try to shadow and get as many hours shadowing you can in different settings just to see if that's a good fit for you. Because I know that there's been
Excellent.
instances like we had a student in the hospital before and they came in and sometimes in the hospital there's not a whole lot of humility for the patients. You're helping with self-care tasks. And if you're helping with something like toileting, you need to be
That's
able to
true.
know that that's what you're going to be able to help the patient with.
I think this is a big thing in healthcare setting where people have a lot of perception outside of the healthcare setting, and
Yeah,
it's
for
pretty
sure.
intimidating being in the healthcare setting, especially school going children or college going kids who want to pursue different aspects of healthcare as their profession. I think what you said is perfectly right. They should come and shadow and understand what happens in the healthcare setting, and they make their decision.
Yes.
That's the best thing. So, in terms of pursuing occupational therapy, what is the sequence? Like you go to high school, then is there a bachelor's degree, or how do you proceed after your high
Well,
school?
that you have to
What are the
get
hoops?
your core undergrad classes and you apply. It's a master's program at WVU. So I applied. And then once I was accepted, the next 3 years, the first 2 years are your undergrad years there. And then your last year is your master's. So you just go straight through once you apply.
Mhm.
There are other ways of going about it. You could get a bachelor's degree and then apply for your master's. You could get a doctorate as well. I have friends that have their doctorate degree. That's a little bit more research based after that. But I think it's different depending on the schools. And there's also people who are, occupational therapy
That's right.
assistants that do the bridge. So they have the 2 year associate's degree and then they bridge to the OT. So that's sometimes like weekends. I'm not sure. I think WVU got rid of theirs. So I'm not sure about that one as much.
Okay. That's fine. I think that kind of information is important for somebody who's pursuing. The other thing I want to know is what is quality of life for an occupational therapist? Somebody
What is,
young wants to
repeat
hear
that. I'm
from you.
sorry.
Quality of life. How do you time your work and your life outside of work?
It
Is it
can be
hectic
obviously like
or
I have said I work at a couple of different places, so I guess I'm a glutton for punishment. I enjoy my job. So, yes, in any job that you have, whether it be healthcare or OT, you've got to find that balance of when to leave, especially in healthcare. It could be taxing. You grow to have, care about your patients and their well-being, but you need to learn, where that cutoff is too, so you can protect your own mental health.
that's right. I mean, can you make a choice where you're going to be specializing only in one particular aspect of occupational therapy? Can you practice only that, or is it always a
Yes, you can
wide range
definitely
of practice?
specialize, especially if you're going to be in outpatient settings or inpatient rehab. For example, inpatient rehabs typically have like a stroke team or a TBI team or a spinal cord injury team. So you can get
That's right.
specialties in that and focus on that. As well as, I mean, if you want to just do pediatrics, you could do outpatient pediatrics and school based or birth to three. So you're doing home health and with birth to three. But if you're in a hospital setting, you got to kind of do it all. So it just depends on what setting you're going in. But yes, you can.
Okay. Now,
Yes.
you have had good experience so far in your career as occupational therapist. Do you have a
Yeah, yes, that's
preference
why I
for
got
anything?
the NDT certification. I like neurodevelopmental. I like stroke patients and TBI.
Good.
It's a challenge. It's something different every day. So I like something to challenge me. Yeah.
Right. It is a challenge.
Yes.
It is a challenge with stroke patients. Sometimes you go long-term therapy. And my understanding about neurodevelopmental therapies or stroke rehabilitation is the first 6 months is pretty critical and important, and how much function they regain. That pretty much determines what's your long-term outcome would
Yes
be.
and no,
Correct me if I'm
because
wrong.
the NDT certification kind of taught us,
Okay.
you're always analyzing movement and posture. So your whole body is connected to your spine. So you're looking at the pelvis all the way up. If you're Yes, in those first 6 months it's important, but you've got to focus on that in the first 6 months. If you have any, let's say later down the road, the patient, had a compensatory strategy where they were this arm didn't work as well, so they're always kind of leaning over to use their arm correctly. Then that causes injuries down the road. So I'm sorry, my dog is jumping on me. Um, can we
That's
start that
okay.
one over?
Okay. So my understanding in terms of stroke rehabilitation is the first 6 months is important in terms of recovery. What recovery they make in the first 6 months is pretty much is going to determine the long-term outcome. Is that true, or correct me if I'm wrong, Ashley?
Yes and no. The first 6 months is important. You want the most intense therapy that you can get to see the best progress. But a lot of times it could take years you can still continue to make progress. It just might be slower. I always dislike when patients say, well, I'm a year out, so I can't make any more progress, is what I've been told, because I've seen situations where, you know, we can make further progress, especially with the NDT certification. What we look at is movement analysis and posture. So, for instance, if a patient, you know, let's say they were flaccid on one side, they were paralyzed on one side from their stroke. So they've learned all these compensatory strategies in order to make themselves independent, which is a good thing. But at the same time, if they're not using those muscles correctly, then they're causing injury probably to the opposite side. So, what we look at with that certification is correcting those compensatory strategies to get more normal movement, and then you'll see increased independence from there as well. Now that takes time because it's, with a brain injury or a stroke or a brain injury, it can take a long time. But yes, you can still make progress after. It's just going to probably
Okay.
be a lot more work and longer period of time.
Good. Is there something you want to add to our discussion?
Yeah, the only thing I'd like to add, we had talked about before, the differences in therapies, because a lot of times
Okay.
we get combined with PT. It's always therapy, and people don't really recognize the difference between physical therapy and occupational therapy, or speech therapy and occupational therapy. So I'd like to talk about kind of how we complement each other versus and how we're
Go ahead.
different.
That's very important. I
Yes.
mean, I'm also one of those healthcare professionals who have made that mistake many
Yeah.
times.
So, well, physical therapy and OT, we complement each other really well. So, and a lot of times they'll co-treat together, which is good because we're working essentially for the patient to be independent. But physical therapy is going to look more at, their strength, their range of motion, and their gait patterns, and improving all of that, as well as like balance. OT is looking at their function within those tasks. So if we are, let's say, the patient in the hospital and physical therapy and OT are co-treating together, PT is going to be looking at their transfers and their gait to walk to the sink, to brush their teeth or whatever. OT is also looking at that, but we're also looking at their function to be able to do the task at hand.
Uh-huh.
Where speech, we kind of overlap with each other because speech addresses cognition, speech and language, and swallowing. OT focuses on cognition as well, not as in depth as speech may. And we also look at, self feeding. So speech is going to look at the swallowing aspect of it, whereas OT is going to look at utensil to mouth and making sure the patient can get the food to their mouth and be in the right
Perfect.
posture to swallow correctly. So honestly, they all complement each other really well when they get to work together.
It's important, even though there are differences among occupational therapy, speech therapy, and physical therapy. I think what you said is excellent and perfectly right, is they complement each other.
Yeah, for sure.
I think that's it. So, any take home points, Ashley? Final thoughts? Anything you want to say?
I think we covered
I think
most of it. Yeah.
We talked about a lot of stuff. I think this is a great discussion. There is a lot of misconceptions about what is occupational therapy, what is physical therapy, and how to refer, when to refer, what are the different aspects of it. And as a healthcare professional, a lot of times we don't know when to refer and whom to refer to, right?
I say the take
And I
home
think,
message is if you think that they could potentially benefit from OT, then make the referral and we could always do an evaluation to see if they do. But if there's any
thank you.
deficit, then
That's the key thing.
yeah.
So this has been a great discussion, Ashley,
Thank you.
and I'm really thankful for coming on my show. And I know I worked with you. I know what your expertise is. And as I said in the beginning, this has been long awaited
Yes.
with few hoops. Thanks a lot for coming on the show and giving your expertise on occupational therapy. Hi, friends. This is, again, a fantastic show. This is what we do on We Talk Facts. Until next time,
Thank
see
you.
you again. Thank you,
Thank
Ashley.
you.